Second presenter today to deliver his presentation.
Good afternoon, everybody. It's a pleasure for me to stay with you, and I want to thank you, the Ethical and the Scientific Committee. My focus is bone modifications around trabecular porous implants inserted with and without primary stability. It's a randomized controlled trial with 3 years of follow-up. So I will speak about bone modification and not only about implants. We know that starting from primary stability, we want to achieve a secondary stability, meaning biological stability, and with this, osseointegration. But what happened in the cases in which we don't have primary stability? Can we also achieve osseointegration? Also, literature is very poor on this theme, so we have only one in Orange Santarno and Morris that 20 years ago they published 78 implants with a prolonged healing period they integrated. Then we have Villa Polimeni, who has only a clinical case report, and our previous studies 2 years ago with 10 cases in wide extraction sockets who integrated. So, starting from this point, we received the Ethical Committee approval from the Department of Dentistry and Oral Surgery General Hospital of Bolzano. And the inclusion criteria were 4 walls wide post-extractive sites in posterior region of maxilla and mandible due to infection or local chronic inflammatory reactions, fractures, or periodontitis. The aim of the study was to state histologically, radiographically, and clinically the results. So, histologically, the confirmation of bone ingrowth and implant osseointegration. Radiographically, the assess of bone modification and degree of bone absorption. And of course, clinically, the evaluation of the biological stability after healing period and provisional loading. The materials were titanium with the tantalum trabecular midsection, homologous fine particulate as allograft, resorbable membrane on bovine pericardium, and APTFA suture. The surgical procedure in the cases we not achieve the primary stability was to put first the implant and then to stabilize the implant with the allograft, covering with membrane and suturing. The study design includes 50 implants inserted with 35 Newton torque centimeter, and only 27 were with primary stability, 23 were without a primary stability at this torque. Accordingly, with the literature from Krakanovic, Albrechtsson, and Venneberg, in there we know in bone defects it's difficult to achieve the same results, meaning stability. So the question is, can we really have the same results in cases without primary stability and with the primary stability? Histologically, we prove that inside the implant, the bone is going in, so we can speak about osseoincorporation. Radiographically, we have cases that are very difficult to achieve also an apical primary stability due to the bone defect, and here to the alveolar nerve. So from the start, after 5 months of healing, the resting bone is indistinguishable from the allograft, and after 6 months of restoration, you see bone modification around the implant. This is definitive restoration after 3 years of loading. So from the beginning to the finish line, we see the bone modification are very clear. In pictures, after tooth extraction, after reopening the flap, the implant, it's only in the middle of this four-wall defect, and then with allograft resorbable membrane, we close. Also the soft tissue thickness is good, and we realize the provisional herniation and then a definitive restoration. So, meaning about bone loss. Accordingly, with the literature, we have 0.4 millimeter of bone loss, but more than this, we have the results with the ISQ values. So look please at this graph. In red, from 0, after 5 months of healing, we achieved more than 65 in mean value of stability. And this increase during the 6 months of provisional loading, so achieving the same results as with primary stability. So the question, can we achieve the same results? The answer is yes. Let me go to the conclusions. Bone modification around the implants inserted with or without primary stability are the same. Primary stability seems to be not crucial for achieving osseointegration. Biological stability occurs independently of the percentage of mechanical stability. Biological stability, bone modification, also with allograft, so with bone regeneration procedures, have the same results. After 5 months of healing, all the implants achieve optimal stability. After 6 months of loading, the test and control group have the same ISQ values. And finally, after 3 years of follow-up, no adverse bone modification occurred. So I wanted to thank you for the kind attention. Thank you all.
Thank you very much for this presentation.